All right, good afternoon, everyone. Can everyone hear my voice? All right, so let's go ahead and get started today. So starting today, we are venturing into this different part of the class where we're going to exclusively talk about diseases of major body systems. And today we're going to start off by talking about respiratory diseases. Now, before I get into talking about these different diseases here, I wanted to come up with like a list of things that as you're studying that I think you should focus on. And so I want to go through this first here. So for the next few weeks here as we're going through this, while all of these are important, probably the one of the more important aspects of what you need to know here is the organism. So because a lot of the diseases that we're going to talk about were caused by are caused by the bacteria on your bacteria list or the viruses on your virus list, and even some of the fungal organisms, protozoans that you had to learn. So if you have a good handle on those organisms that you've been learning the entire semester, you've basically got about 50% of what you need to know already done for what you need to know for these sections. What we're going to expand on beginning today are some of the major signs and symptoms of these diseases. We're also going to talk about like any specific treatments or even vaccines. So like if there, as I'm going through here, if there are major vaccines that I talk about that can be used to, prevent any of these diseases, you should definitely know them. And then another thing that, if you've looked in your notes, for a lot of these diseases, it'll mention the incubation times. And while those are important, I don't want you to know every single incubation time. And what I want you to focus on are the diseases that have very, very short incubation times, like, maybe a day or so, and the ones that have very long incubation times, like months or years. And as I go through, I will specify what you need to know. If you have incubation times that are like in the middle range, like if it's like 5 days, 10 days, whatever, you don't need to know those. So we're going to focus on mainly very, very short incubation times and really long incubation times. Right now, so let's go ahead and get started here with respiratory diseases. Now, one of the things that I will do as I go through these different diseases of different body systems is I'll take a very brief overview, really brief overview of the different components of these body systems. It's not going to be in any detail like you would get in your anatomy class. And so to kind of start this off, since we are going to be talking about respiratory diseases, many of you that have had any sort of study on respiratory diseases know that the respiratory tract is composed of the upper respiratory tract and the lower respiratory tract. The upper respiratory tract includes parts of the nose, the nasal epithelium, the pharynx, the middle ear, even the tonsils. And the lower respiratory tract is everything below that. So the trachea, the bronchi, and especially the air sacs in the lungs called the alveoli. All right. There are other structures that you probably, again, remember, from your other classes that are pretty important in the respiratory tract. So for example, the nasal conchae. Remember that you have a nasal conchae in your ethmoid bone, and then you also have the inferior nasal conchae, which are just in two separate bones by themselves. And those nasal conchae, they basically serve to kind of circulate the air as you breathe it in through your nose and then push it up against the nasal epithelium. And you might also remember that your respiratory tract is lined by something we call the mucociliary escalator. It's basically a pseudostratified ciliated epithelium, so that anytime you breathe in air, what we want is if there's any debris or dust or bacteria or anything like that in that air that you're breathing in, we want that stuff to kind of stick to the mucus layer that lines it, and then the cilia move everything out, up and out, so to prevent anything from getting down to your lungs. Also, in your lungs, you have these white blood cells that are called alveolar macrophages. This is an example of one. And what these alveolar macrophages do is that their job is to phagocytose any bacteria or virus that gets down in there, to prevent it from spreading anywhere else. Now, another thing that I'm also going to discuss as we go through these different diseases of major body systems is whether or not in any part of these body systems there are any normal flora bacteria. Now, in the upper respiratory tract, there are many. I mean, there's different types of streptococcus bacteria, staphylococcus bacteria. I mean, there are just many, many different types. But in the lower respiratory tract, there should not be any. I mean, if you have bacteria in your lower respiratory tract, you basically have a lower respiratory tract infection, okay, which you don't want. All right, now we're going to begin our discussion today by talking about upper respiratory tract infections. Upper respiratory tract infections can be divided up into things that are called rhinitis, which is an infection and inflammation in the nose, pharyngitis, which is an infection and inflammation in the pharynx, sinusitis, which is an infection and inflammation in the sinuses, and then epiglottitis. That's an infection and inflammation in the epiglottis, which is a little flap of cartilage that folds over your respiratory tract whenever you swallow. It helps to direct everything down your esophagus and prevent it from getting into your respiratory tract. Okay. Now, we'll start off with upper respiratory tract infections caused by viruses. And there are a lot of different viruses, as we know, that can cause upper respiratory tract infections. But the one that I want to focus on the most is the common cold. There are a lot of different viruses that can cause the common cold, but about 50% or more of all cases of the common cold are caused by the rhinovirus, some species of the rhinovirus. Now, you and I, we basically get colds every year. And the reason for that is because whenever you get a cold, you're getting infected with one particular species, one strain of the rhinovirus. And when you get infected with that strain, you can never get infected with that particular strain ever again. But the next time you get the cold, right, is you're going to get infected with another strain of the rhinovirus. So that's why it's kind of hard to develop an immunity against. Now, like I said, the rhinovirus is not the only thing that can cause the common cold. Even the coronavirus causes about 20 to 30% of all the remaining cases. Now, when I say coronavirus, I'm not talking about the strain that's causing the pandemic right now. The coronavirus has actually been with us forever, and it can cause the common cold. The difference between the garden variety coronavirus and the one that's causing the pandemic right now is the one that's causing the pandemic right now is a strain that, at least when the pandemic first hit, was a strain that no one was ever exposed to. It was a completely new version of the virus, and because no one was ever exposed to, there was little to no immunity against it, and that's why it's causing problems, with a lot of the symptoms and even fatalities that go along with it. Right? But again, since the rhinovirus is the cause of the majority of cases of the common cold, I want to focus a little bit more on that. So the rhinovirus, it tends to pretty much infect the nasal epithelium, hence the name rhino. Rhino, the prefix there, rhino, really means nose, has anything to do with the nose. It infects the nasal epithelium, causes a lot of infection and inflammation there, and a lot of that would cause a lot of triggering of increased mucus production that would then cause a lot of coughing and sneezing and that kind of thing. So it tends to infect mainly that area, and it's usually transmitted through a droplet or fomite transmission. Now, the rhinovirus, you might remember, is a naked virus. And naked viruses are very versatile in terms of the ways that they can be transmitted. Not only can they be transmitted in airborne droplet or droplet transmission, but they can be transmitted through non-living things like fomites, because since they're a naked virus, they're a little bit more resistant to those drying out conditions. Okay. we've all had the common cold, right? I mean, and so when you do experience the common cold, you get like a scratchy throat, runny nose, that kind of thing. You rarely get a fever as an adult, although some kids that get the common cold, they can get a fever. And there is no cure for the common cold. There's no vaccine for the common cold. The only thing you can do when you do get the cold is to alleviate the symptoms with cough suppressants and antihistamines, and that's pretty much it. Now, the common cold does have an incubation time that you should know. It's very short. It's about 1 to 2 days. Okay, so know that. Now, there's a virus that's called the adenovirus that causes symptoms that are similar to the common cold, but not quite. And the adenovirus can cause something called adenoviral pharyngitis, which is an infection in the throat. And a lot of the symptoms of adenoviral pharyngitis, are very similar to what we would see with the common cold, with the addition of a fever. Many people that do get infected with the adenovirus do experience a fever. So that is something that can happen. It's transmitted the same way through droplets, and the only thing that can be done is to treat the symptoms. It's symptomatic. Now, there are a lot of other viral diseases of the upper respiratory tract that we could talk about. But rather than spend a lot of time talking about individually these diseases, I just want to mention one thing here, is that these diseases that you see here, croup, pharyngitis, sinusitis, otitis, conjunctivitis, they can be caused by any virus, even though they do tend to have their most common causes. Croup, they can either be caused by the rhinovirus, adenovirus, or coronavirus. So, I don't want you to think that it's always one organism causing one disease. A lot of these organisms, they can cause a lot of these other things here, just depending on what part of the body they infect. All right, so those were all of the main viral upper respiratory tract infections that I wanted to discuss. And so what I want to focus on now are bacterial infections of the upper respiratory tract. And what I'm going to focus on first is streptococcal pharyngitis, or what we typically call strep throat. Okay. Strep throat, or streptococcal pharyngitis, is caused by Streptococcus pyogenes. Now, this is a bacteria that we're going to come back to a lot between now and the end of the semester, because it is a very pathogenic bacteria. It has a lot of features about it that make it very, very able to cause disease, and I'll talk about some of those things that it possesses. But Streptococcus pyogenes can cause a lot of different complications from, I don't know, you've probably heard of like the flesh-eating disease caused by flesh-eating bacteria. This is the one of the causes of that, but it has a lot of other things that it can cause. It's a beta hemolytic strep. Does anybody remember what beta hemolysis means? Yeah, it has the ability to lyse red blood cells, exactly. Now, strep throat is primarily transmitted through droplet transmission or fomites. And if you've ever had strep throat, which at some point in our lives we all have, there's usually a sore throat, fever, feeling of fatigue and malaise that usually goes along with it, and pus in the back of the throat. In fact, the fact that this bacteria produces pus has to do with partially how this bacteria gets its name. The species name, Pyogenes, comes from the word pyogenic, which basically means it's a pus producer. It produces pus, okay? The normal treatments for strep throat are 10 days of penicillin, or if a person's allergic to penicillin, they might be given 10 days of erythromycin. Now, like I said, strep pyogenes is a very pathogenic bacteria. It's really nasty, causes a lot of different things. I want to briefly discuss some of the different virulence factors that this bacteria possesses that makes it so bad. One of the enzymes that this bacteria makes is something called a C5 peptidase. Now, C5 is a complement protein. Okay, it's a complement protein, and the normal function for C5 is to attract white blood cells to an area of infection, which is something that you need to happen. If you have somewhere in your body, if you're infected with bacteria or viruses, you want to attract white blood cells into that area so that the white blood cells can phagocytose them. And C5 can actually act like a perfume, attracting these white blood cells to this area. Well, this bacteria produces this enzyme that destroys that, preventing these white blood cells from moving in. Strep pyogenes also has within its cell wall this protein called the M protein, which helps it to escape phagocytosis. This bacteria, what makes it beta hemolytic, what makes it able to lyse red blood cells, is that it produces this toxin, this enzyme called streptolysin, or in some textbooks it's called a hemolysin, right? Something we talked about before is that this bacteria can also produce this enzyme called a streptokinase. This is an enzyme that can allow this bacteria to break down a blood clot. Now you might be thinking, well, why would a bacteria want to break down a blood clot? Well, let's say that you had a cut in your skin and you bleed, and then you form a blood clot to stop the bleeding, but the other reason you're forming that blood clot is to prevent any infections in that wound. Well, this bacteria can still infect that wound by producing this enzyme streptokinase to break down the blood clot and infect the wound. And then, as if that wasn't enough, Streptococcus pyogenes also has this capsule around it. Now, we know that capsules normally protect against phagocytosis, but this is a capsule that's a little bit different. This is a capsule that's made up of something that you have in your body, hyaluronic acid. It's basically a hyaluronic acid-based capsule. And what the bacteria is trying to do, it's trying to camouflage itself. It's trying to make itself look like it's part of you so that your immune system doesn't get rid of it. Some of the complications that this bacteria can cause. We talked about in the immunity section about this disease called glomerulonephritis. This is basically a kidney inflammation where a person might first have strep throat and then later on get this kidney infection called glomerulonephritis. This is basically a sequela, okay, of the original infection. Something else that can happen with strep pyogenes infections is something called rheumatic fever. What happens here is that when you're infected with the bacterium, you produce antibodies against the bacteria, but those antibodies can then attack your heart muscle fibers, especially the area right around your heart valves, and cause the heart valves to get swollen and inflamed, producing what are called rheumatic valves. The problem with these valves is they don't close fully, so you're going to get a lot of regurgitation of blood from the ventricles back into the atrium, and that could cause a lot of like heart murmurs, and because the blood is not flowing properly through the heart, make the heart beat harder. Okay. Something else that can occur is something called scarlet fever, but scarlet fever only occurs in certain strains of Strep pyogenes that produce this erythrogenic toxin, okay, that not all strains do. So I'm going to talk about scarlet fever here. So like I said, scarlet fever is only produced by strains of Strep pyogenes that produce this erythrogenic toxin. It's thought that these strains obtained the ability to produce this toxin by being lysogenized by a bacteriophage. Okay, it's still spread the same way through droplet transmission or fomites, and a lot of the initial symptoms are very similar. So coughing, fever, fatigue, pus pockets in the back of the throat. But what makes this one a little bit different is that the erythrogenic toxin it can spread into the blood and into the skin and cause a bright red rash on the face and the chest, and what's called a strawberry tongue. Okay, it causes the tongue to get red like this and look like a strawberry. The treatments for scarlet fever are the same as just regular strep throat. So 10 days of penicillin or erythromycin if a person is allergic. Now, again, one other thing, as if that wasn't enough, to discuss about strep pyogenes, some other complications, and this would be considered to be another sequela, is something called Sydenham's chorea. All right, now, Sydenham's chorea happens when you're infected with the bacteria, and while you're infected, your immune system responds by making antibodies against the bacteria. Well, some of those antibodies can then cross the blood-brain barrier and attack your basal nuclei. Now, you might remember the basal nuclei from your Anatomy and Physiology 1 class. Can anybody out there tell me what the normal function of your basal nuclei is? Yeah, it basically helps you with smooth movement. So whenever you're performing certain actions, your basal nuclei communicates with your cerebral cortex so that every motor action is appropriate for whatever you're trying to do. But when your basal nuclei are affected by these antibodies, no, your basal nuclei does not produce dopamine. Your brainstem, your midbrain produces dopamine, and that helps to control the basal nuclei as far as what it does. But what happens here is that these antibodies, they attack your basal nuclei, and that causes a person to have a lot of like uncontrollable movements, very shaky movements in their hands. If you look up Sydenham's chorea on the web, you'll find some videos on it. But it doesn't last long. It's a very brief sequela. It can last maybe a few weeks or a few months, and then it kind of goes away on its own. Okay, now moving on to another bacteria and another disease, epiglottitis. All right, epiglottitis is a disease that is caused by this bacteria here, Haemophilus influenza type B. Okay, so it's very specifically the type B strain of this bacteria. Now, a couple of things about this bacteria. You can see that it has the species name influenza, but does this bacteria cause the flu? No. What causes the flu is the influenza virus. What happened is that a long time ago, when investigators were trying to discover the cause of the flu, they noticed that a lot of the people that had the flu also had this bacteria. So they just wrongfully assumed that this bacteria caused it. And then, they later discovered that was the influenza virus. So unfortunately, though, that it's unfortunate that this bacteria has retained its species. Honestly, they should change it to avoid any confusion. But anyway, so Haemophilus influenza type B, it's usually spread through droplet transmission. And what it does, it infects the epiglottis, which is, again, it's this flap of cartilage that folds over your respiratory tract, preventing things from getting down to your lungs and directing things down more into your esophagus. But this epiglottis gets infected and gets swollen and inflamed. And when a person swallows or tries to swallow, it's very, very painful. It's so painful that they can't drink water, eat food, and they can't even swallow their own saliva. It's that painful, that there's so much discomfort with it. So the thing is that we don't really see a lot of cases of epiglottis anymore, because most kids within the first month, right after they're born, are vaccinated against this using what's called the Hib vaccine. It's one of the first vaccines that babies get. Now, this Hib vaccine, not only does it prevent epiglottitis, it also prevents children from getting another very serious disease that this bacteria can cause. Does anybody remember what other disease Haemophilus influenza type B can cause in addition to epiglottis? It should have been on your, yes, meningitis. Yeah, there's a type of childhood meningitis that this bacteria can cause. So when a baby's vaccinated against it using the Hib vaccine, it protects them from getting epiglottitis, and also that type of meningitis caused by this bacteria. All right, otitis media. Well, otitis media is a middle ear infection. As you might remember, your ear is divided up into three parts. You have external ear, middle ear, and then you have an inner ear, kind of embedded in the temporal bone. And so what we're talking about specifically is an infection here in the middle ear where the ossicles, the malleus and the incus and the stapes are located. Well, middle ear infections, they don't start in the middle ear. They actually start down here in the pharynx. And so any bacteria that causes that's in the pharynx can travel up the eustachian tubes and into the middle ear. So middle ear infections really start off as a pharynx infection in the back of the throat. And, any age group can get a middle ear infection, but children, as you may know, are more prone to getting middle ear infections than adults. And that's because their eustachian tubes are shorter compared to adults, which is much longer. So it's easier for bacteria to travel up a short eustachian tube in a child than it is, longer eustachian tubes in an adult. Now, it's really hard for me to say that, only this bacteria or this bacteria causes middle ear infections, because any bacteria that's in the pharynx can easily spread into the middle ear. But if we look statistically at all the different causes here, the most common cause, now again, I'm not saying the only cause, but the most common cause of most middle ear infections is Streptococcus pneumoniae, which is also a bacteria that causes pneumonia. But again, there's a bacteria called Moraxella that can cause it, and even Strep pyogenes, the very same bacteria that we just talked about that can cause strep throat, it is possible for it to cause middle ear infections. If you have ever had a middle ear infection, or if you have kids and they have ever had a middle ear infection, the number one treatment for it is amoxicillin or Augmentin. Now, I'm not a doctor, but when doctors do use an otoscope to look into the ear to see if a person has a middle ear infection, what they're looking for is a normal ear. The ear, there should not be any redness, there shouldn't be any pus buildup. But if a person has otitis media, as you see here, there's a lot of redness right around the middle ear, and you see a lot of pus, representing there's a lot of pus buildup and fluid built up behind the middle ear. Well, the problem with that is that when a person has this infection in their middle ear, that fluid builds up and builds up and builds up and has nowhere to go. So pressure increases. And the more pressure that increases, if it's not treated, if this infection is not treated, it could cause a perforated eardrum, which is a ruptured eardrum. So that's why treatment of middle ear infections is extremely important early on. There are some children that, for whatever reason, they are very prone to getting middle ear infections. And to prevent their eardrums from getting perforated and them suffering from hearing loss, they put tubes in their ears. Okay, and the tubes are supposed to equalize the pressure between the middle ear and the outside of the ear. Okay. Now, a lot of other diseases we could kind of harp on, like sinusitis and otitis media, but what's really important is that especially the upper respiratory tract, you have to understand that all of those areas, the sinuses, your eyes, the pharynx, they're all connected to each other. So if not treated, an infection in one part of the upper respiratory tract could easily spread to another part. So for example, if a person has sinusitis, it could become pharyngitis, or vice versa. Pharyngitis could become sinusitis. If a person has an infection in their nose, whatever bacteria or virus is causing that infection could spread up the nasolacrimal duct into the eye and cause a viral pink eye. Okay. And as we just saw, anybody that has an infection in their pharynx, their throat, it could spread and become otitis media, a middle ear infection. So again, that's why treatments of a lot of these upper respiratory tract infections are so very important. All right, well, continuing on with bacterial lower respiratory tract infections, we need to talk about diphtheria. Now, we don't see a lot of cases of diphtheria anymore because most kids are at a very early age are vaccinated against it. And I'll talk about the vaccine here in a minute. But the bacteria that causes diphtheria is Corynebacterium diphtheriae. It's a gram-positive pleomorphic rod. What does pleomorphic mean? Well, yeah, it can assume many shapes. So it's a rod most of the time, but it can look like a vibrio at some times, and it can be really small at other times. So it's just, you know, it's hard to pin it down into one shape. Now, this bacteria, it produces this toxin that is called the diphtheria toxin, okay? And this toxin actually can have a lot of effects, but one of its effects is that it kills a lot of the epithelial cells in the back of the throat, and it causes a lot of buildup of pus and clotted blood and that kind of thing, and it produces this very leathery, very thick membrane in the back of the throat that's called a pseudomembrane. And what that white stuff you see back there is an example of a pseudomembrane, and it's just a very thick membrane. It's so thick that it has the consistency of leather, which interestingly enough, the word diphtheria means leather in the Greek language. And so just kind of imagine, like, you've got in the back of your throat, you have this thing in the back of your throat that feels like a piece of leather stuck in the back of your throat, right? It'd be very hard to breathe. And so when a person has diphtheria, that pseudomembrane has to be constantly like peeled off to avoid the person from suffocating, basically. Now, the diphtheria toxin, it's a very powerful toxin, as I said. Not only can it have that effect on the cells in the back of the throat, but if it spreads into the blood, it can cause damage to the brain, and it can cause damage to the heart. So it can be a very fatal disease if not treated. The best way, though, to prevent this is to get vaccinated. The primary vaccine that kids get starting at around 2 months of age is the DTP vaccine. Now, this vaccine, it's not a vaccine just against diphtheria. It's a vaccine against diphtheria, tetanus, and pertussis. And this is a vaccine against the toxins that are made by this bacteria. And does anybody remember, what do we call a vaccine that protects you against a toxin? What type of vaccine is that? That's correct. It's called a toxoid. Very good. So it's a toxoid. What they basically do is they take the real toxin and they treat it with chemicals so that it doesn't cause you to get sick, but it still retains its antigenic properties so that your immune system recognizes it, so that if you're ever infected with the real thing, you can mount a response against it. Now, let's say that, let's say that a person was not vaccinated against this disease for whatever reason. We don't need to get into that. And they contracted diphtheria. Well, how do you help them? Well, you can give antibiotics to kill the bacteria, like erythromycin, penicillin. But if that was all you did, and nothing else, the person would still have diphtheria. You also have to give an antitoxin. And the antitoxin is an antibody against the toxin. So this would be a type of passive artificial immunity. And so the idea there is that these antibodies would they would give you these antibodies, and the antibodies would neutralize the toxin that you're exposed to. All right. One of the things I try to do when we get into diseases is try to relate incidence rate, like epidemiology to these things. And so if we look at the incidence rates of global incidence rates of diphtheria between 1980 and like right around 2006, if you look at the blue bars here at 1980 and going all the way down to 2006, we can see here that the incidence rate has dropped. Well, why? Well, the reason that incidence rates have dropped is if we, well, what we need to do is look at this blue line here. The blue line represents the increase in the amount of vaccines given worldwide. So this is why, vaccines are really important. With greater vaccine distribution and greater vaccine, people getting more vaccines, the incidence rates for something like this has dropped drastically. All right. So those were all of the bacterial infections of the upper respiratory tract. Well, let's get into talking about some bacterial infections of the lower respiratory tract. And we're going to start off by talking about pertussis, which is also called whooping cough. This is caused by a gram-negative bacteria. And this bacteria here, it is a bacillus, but it's a very small bacillus. It's so small that a lot of microbiologists call it a coccobacillus, kind of in between a coccus and a bacillus. It's like a really small oval, but technically it's a bacillus. Okay, it's a rod-shaped organism. Now, the bacteria is usually spread through droplet transmission, where a child that has it would spread it through coughing or sneezing. And what really is important here is that this bacteria, once it gets into the throat here, it produces two toxins. One of these toxins is referred to as the pertussis toxin. And what the pertussis toxin does, what this pertussis toxin does, it causes the cells in your respiratory tract to secrete a lot of mucus. So we produce mucus there anyway, but we're talking like 3 or 4 times the normal amount of mucus production. So you develop this really thick layer of mucus there. Okay. Now, in addition to that, as if that wasn't bad enough, this bacteria makes this other toxin called the tracheal cytotoxin. And the tracheal cytotoxin, if you remember, your respiratory tract is made up of a pseudostratified ciliated epithelium. And what this tracheal cytotoxin can do, it can paralyze the cilia and then eventually kill the cells that have the cilia. So normally those cilia, when they're functioning, they help to move everything up and out, to push everything that's trapped in the mucus layer there. Well, now you don't have any cilia, okay? And so there's no cilia, but there's more and more mucus, and that mucus has got nowhere to go. And that's a problem. That can actually cause a person to have these very, very extremely violent, almost convulsive type coughs and suffocate, okay? And the cough that a person with pertussis has, it's not like a normal type of cough. It's a very wheezing kind of cough. If I had to demonstrate it, it would be like that kind of thing. It's because of the difficulty, in breathing. Now, pertussis has 4 different stages. Okay. The very first stage is about a 1 to 3 week incubation stage, where there's not any signs and symptoms, but then the person will enter into a very long prodromal phase. Remember, the prodromal phase of a disease is where they're experiencing some mild symptoms. Okay, maybe some cold or flu-like symptoms, but they're not really sure what they have. And this stage is called the cotural phase. It can last a couple of weeks or so. But during this time, not only are they producing more mucus, but that tracheal cytotoxin is also being secreted, and they slowly but surely enter into what's called paroxysmal stage. This is where the tracheal cytotoxin is now killing the ciliated cells, and now the mucus has nowhere to go, and they start having these very, very violent coughs. Okay. Now, these people would have to have a lot of supportive care, you know, respirators, oxygen masks, that kind of thing, and the mucus would have to be completely, constantly drained out while they're suffering from this disease. And so, this paroxysmal stage can last 6 weeks or longer. But with proper treatment and care, a person can enter into convalescence where they regain their pre-diseased state. Okay. So again, it's usually transmitted through droplets, and some of the initial symptoms are, runny nose, cold-like symptoms, but then eventually progresses into violent coughs. The best prevention for pertussis is to immunize, vaccinate. Okay, get the DTP vaccine. The AP part of this is what protects against pertussis. It's the pertussis toxoid. Okay. Now, if a person wasn't vaccinated and they got pertussis, one thing that can be given to treat is erythromycin. And again, just to kind of relate this to epidemiology, between like 1922, if you look at the map here, 1922, and now, the incidence rates of diphtheria have greatly dropped, and that's really because of the vaccine. But there's something troubling that we've started to notice. If you look at the latter years here, like probably beginning like in the 2000s, there's this, and if you take this part and kind of expand it here, we're seeing this trend for an increase. All right, and that's in large part being attributed to lack of vaccines for whatever reason. Again, some people are just not vaccinating their children. Okay. All right. So now we're going to get into our next lower respiratory tract infection, tuberculosis. So tuberculosis is caused by this acid-fast bacterium called Mycobacterium tuberculosis. And because it's acid-fast, this means that within the cell walls of these bacteria, they have a very high concentration of this lipid called mycolic acids. Now, these mycolic acids present a problem. They're very hard to penetrate. And this is why acid-fast bacteria are very resistant to disinfectants. They're also very resistant to drying out conditions. So if the bacteria is if it's within like saliva or mucus, and let's say that the saliva or mucus that they're in dries up, well, the bacteria doesn't dry up and die along with it. It can still remain viable. Something else about this bacteria is that it's a slow grower. It has a fairly long generation time. The generation time for this thing is 12 hours or longer, which the consequence of that is that it has a pretty long incubation time. The incubation time, which is something you need to know for this thing, is 3 months or longer, and that's in large part again attributed to the fact that it has such a long, slow growing time. Now, let me talk a little bit about the pathogenesis of tuberculosis. So the first thing that would have to happen is that a healthy individual would have to be exposed to a person that has an active form of tuberculosis. And if that person coughs or sneezes, they release respiratory droplets that contain the bacteria. And the healthy individual would inhale those respiratory droplets that then travel down into the alveoli. Well, remember that in your alveoli, you have these alveolar macrophages, whose job is to just phagocytose the bacteria or anything that gets in there. And they're going to do that. They're going to phagocytose it. But they have a problem. Because these are acid-fast bacteria, the macrophages cannot digest the bacteria. So what ends up happening is that the bacteria then uses the macrophage to replicate. Okay, kind of uses a little incubator to replicate over and over again. And the macrophage just, it fills up with the bacteria. Eventually, it pops by lysis, releasing more bacteria. Okay, now, what happens then is that once those bacteria are out, your immune system sends in more macrophages to phagocytose them. This is kind of I mean, if you have a healthy immune system, this is what you want to happen if you were exposed to this bacteria. So your immune system sends in more macrophages, and then the bacteria replicate inside of those macrophages, burst out of them, and this whole cycle repeats. And your immune system will send in more and more macrophages. And so what we get here is the very beginnings of the formation of a tubercle. Okay, a tubercle is basically nothing more than this big ball of macrophages that are trying to seal off that infection, prevent it from spreading to other parts of the lungs. And, because the alveoli, this is the major site for exchange of oxygen or gases between the air in your lungs and the capillaries, there's a very rich blood supply underneath there. And so if any of those bacteria get into the blood, they can travel to other organs and cause major problems there. Okay. So this whole thing kind of happens over and over again. And eventually, again, if the person has a healthy immune system, they're not immunocompromised, and they, eventually you develop a tubercle. Okay, so this is just a big ball background. And what your body's trying to do is prevent the bacterium from spreading to other parts of the lungs and into the blood. And your body, to further prevent the bacteria from spreading around the tubercle, collagen fibers are deposited, just really in an effort to really seal off this infection. And when this happens, okay, so again, if you have a healthy immune system and you were exposed to this bacteria, this is what you would want to happen. And it is tuberculosis, but this is a type of tuberculosis that we call primary tuberculosis. It's a self-limiting disease. It's not, these people that have primary tuberculosis, even though they are infected, they are asymptomatic. In other words, they have no signs and symptoms, and they are not contagious. Okay, they are not contagious at all. So you could be around them and not worry about getting infected. All right, but let's say that they become immunocompromised, or when they were initially infected, they were already immunocompromised. Let's say they had AIDS or something like that. Well, even though the immune system tries to form tubercles in the lungs, they're very weak. And what ends up happening is that the tubercles rupture and the bacteria spread to other parts of the lungs and also to the blood underneath. And when they get to the blood underneath, that causes the bacteria to spread to other organs. And when that happens, not only is this secondary reactivated TB, but this is actually disseminated tuberculosis. Okay, disseminated tuberculosis. Okay, disseminated means spread throughout the body. Okay, now a long time ago they used to call this disease consumption. Okay, they used to call it consumption because when the bacteria spread to other parts of the body, it would consume the body. It would actually consume those other organs and tissues. So just to kind of, yeah, so in secondary reactivated TB, that can happen. Yes, they can cough up blood. That is exactly right. You're right. Okay. So just to kind of recap here, in primary TB, it's not contagious. There's no symptoms here. And again, if this person continues to have a very active, very strong immune system, that'll be the end of it. I mean, it's very possible that their immune system will eventually just totally get rid of the remaining bacteria. But in secondary reactivated TB, this would normally happen if their immune system become weak for some reason. Then this is where the person experiences really violent, symptoms, and it's very possible for it to spread to other organs and tissues if it's not contained. All right. Now, the tubercles. If a person were to get an X-ray, normally lung tissue doesn't show up on an X-ray, but the tubercles do. You can see the examples here of tubercles, these little white spots there. With disseminated tuberculosis, this is where the bacteria spreads to other organs and basically damages those organs. What you actually see in this picture, this is actually a picture of a spleen from a person with disseminated tuberculosis. And you can actually see tubercles forming in the spleen. Okay. Now, again, relating this to epidemiology. If you look at this map, what this map is showing you here is the prevalence of tuberculosis around the world. Now, I know this is in 2007, but it's probably gotten worse now. But first of all, does anybody, when we say prevalence, what does that mean? Yeah, so it's looking at old and new cases, all right? And so it kind of gives you a better idea of like the staying power or how that particular disease is persisting in the population. And from the map, what you can see is that the countries that are in the yellowish colors and the brighter yellow colors, those are countries where the prevalence rates of TB are much higher than normal. And the countries that are in blue have pretty much zero prevalence, zero cases of TB. One of the reasons why a lot of these countries that are in yellow have such a high incidence rate are, one, that people that live in those countries tend to live in very, very close quarters. They very close quarters, and when you live in close quarters with people that are infected, it increases the chances of the spread of the infection. Also, HIV and AIDS. One of the more common, in a lot of these countries that are in yellow that have really high incidence of TB, there's also a really high incidence and prevalence of HIV and AIDS. And one of the more prevalent infections that AIDS patients get is TB. Makes them more susceptible to that. Okay, now, so again, just to recap here, some important facts here. Again, the organism that causes this is Mycobacterium tuberculosis. If a person has primary tuberculosis, they're asymptomatic, they have no symptoms, but if it's secondary reactivated TB, the symptoms could include night sweats, fever, weight loss, coughing, and the incubation time for this is 3 months or longer. If a person does get tuberculosis, they're usually put on a combination of what we refer to as the anti-TB drugs. What I'm going to list here are, they're considered to be called the first line of defense drugs. We talked about these in the antibiotic section, so they would definitely get isoniazid and ethambutol. These are essential because these drugs, isoniazid and ethambutol, they target mycolic acids. Right? They would also get other antibiotics that you couldn't give by themselves. So another antibiotic that they would get is rifampin. And the target of rifampin is RNA polymerase. And sometimes they would even get another drug called streptomycin. Streptomycin prevents protein synthesis. Okay, but if you want rifampin and streptomycin to work, you have to give isoniazid and ethambutol. In other words, let's say that I only gave a person rifampin just by itself, then it would have no effect because it can't penetrate the mycolic acid. So that's why you have to give these two drugs to get rid of the mycolic acids, and then that gives the other drugs more of a chance to penetrate the cell. Okay. All right. Now, so those are kind of our first line of defense drugs. Unfortunately, one of the things that's also happening that we're seeing more and more of is that with overuse of these antibiotics, we're starting to see more and more people come down with what are called MDRs and XDRs. And MDR is a multiple drug resistant tuberculosis strains, and XDRs are extremely drug resistant, and they're almost impossible to treat. Okay. Now, the other thing that I want to mention about tuberculosis is that there is a vaccine. It's called there's a vaccine against tuberculosis. It's called the BCG vaccine. All right. And the thing is that it's not given here in the United States. It might be given to in a lot of other countries where especially the incidence and prevalence rates are higher, but we don't give it in the United States. And that's because, well, let's go back to the map. In the United States and other more developed countries, the incidence rates are, very, very, very low. Okay. And because the incidence rates are very low, we don't give it. And if there's anybody out there, if you've ever been vaccinated against tuberculosis, at some point you've probably had to get a TB test. What happens when you get a TB test? Right, it comes back positive. Even though you're not infected, it comes back positive. So think about that. If we were to vaccinate everyone in the United States against TB, which we don't need to because it's so rare, then everybody would have to get a TB test. And the only way everybody, if everybody got vaccinated, they would show up positive for TB. And to prove that you weren't infected, you would have to get a chest X-ray to prove you don't have the tubercles. So that would be, very, very difficult. It would be a very difficult thing to do. Okay, so that's why we don't vaccinate against it, because again, the incidence rate here is very, very low. The test. Let me talk a little bit about the test. There's actually two versions of the test. There's what's called the time test and the Mantoux test. The Mantoux test is a little bit more accurate because they're able to inject a very precise amount of the antigen underneath the skin. And the time test, it works, but the amount of the antigen that's in the skin is less accurate. Let's put it that way. So usually they prefer to give the Mantoux test. But if a person is positive, a reaction like this would occur. If you're not positive, or whatever, you don't get this reaction. Okay. Now, so again, while tuberculosis is not much of an issue here in this country, it is an issue in a lot of other countries. It affects 1/3 or more of the world's population. Okay. Okay. All right. Well, that brings me now to talking about something else. Anthrax. Now, the cause of anthrax is the bacteria Bacillus anthracis, and it's really being exposed to a certain amount of the endospores from the bacterium. Now, there's actually three forms of anthrax. The one that we're going to talk about now, which is inhalation anthrax, which infects the lungs. But there's also a GI form, which affects the GI tract, and then there's a skin form. Out of all three, the most deadliest one is the inhalation anthrax, because if a person was exposed to it, there's really it's very rare that people recover from it. Most people that get the inhalation anthrax die from it. Now, the way that a person gets anthrax is they would have to inhale the endospores from the bacteria. It is not spread person to person. So if I had anthrax and I was with you, I wouldn't, I probably wouldn't be there, but there's no way that I can spread it to you. It's mainly through inhaled endospores. And it's rare, but this is a disease that used to be called wool sorter's disease, because the endospores from the bacteria tend to stick to the fur and the hides of certain animals like sheep. And people that were called wool sorters, they would shear the wool off a sheep that would be then used to make items of clothing like sweaters and things like that. And so if the wool on the sheep had the endospores, and as the workers were handling that, the endospores would get aerosolized and they would breathe this in, okay, and they would get inhalation anthrax. The endospores are also considered to be a bioterrorism hazard, because if some malicious group wanted to get access to the endospores, they could use it to infect a lot of people, just aerosolize it, infect a lot of people, and cause them to die. So again, treatment for this, I mean, it can be treated, but it would have to be very, very early on and very, very aggressive treatment with certain antibiotics. But even then, most people do die from it. There is a vaccine against it, by the way. There is a vaccine against it, but the only people that are vaccinated are people in the military who, again, might need it because it's such a bioterrorism hazard, and it's people that are what was I going to say, that might work with some of these animals that have a lot of these things. So they would get vaccinated. All right. So now what we want to do here is talk about some different types of pneumonia. Now, if you've ever had pneumonia, or if you know somebody that has ever had pneumonia, most likely they were infected with Streptococcus pneumoniae, and they had a type of pneumonia that's called pneumococcal pneumonia. This is the most likely cause of pneumonia in most people. There are some other rarer causes, and we'll talk about them later, but this is the most likely cause for it. All right. Okay. Now, this bacteria is usually spread in droplets, and what it does, it causes a lot of inflammation to occur in the lungs, causing a lot of fluid buildup. That's one of the problems here, is a lot of that fluid buildup, making it very difficult to for gas exchange in between the gas in the alveoli and the gas in the lungs. So that's one of the biggest problems with this. Treatment for this could be penicillin, if the bacteria are not resistant, or some other antibiotics like cephalosporins or erythromycin. In very rare cases, like if all other antibiotics didn't work, a person might be given chloramphenicol. But what is one of the problems with giving a person chloramphenicol? Yeah, aplastic anemia. Okay, it's a huge problem where it can affect the bone marrow, destroy the bone marrow, causing a person to have reduced amounts of red blood cells and white blood cells. Okay, so that's why. And there is a vaccine against pneumonia. It's usually given to elderly individuals or people that are most likely to come into contact with the bacteria. But other than that, it's not really given that much. Okay. Now, like I said, there are other types of pneumonia. This is not the only type of pneumonia. Another one, or another group here of types of pneumonia are, we're going to talk about here, hemorrhagic pneumonia, walking pneumonia, chlamydial pneumonia, and even something called Legionnaire's disease. So we'll talk a little bit about those. Okay. So hemorrhagic pneumonia, it's caused by the bacteria Klebsiella pneumoniae. And the reason that this type of pneumonia is called hemorrhagic pneumonia is because not only does it cause pneumonia, but it can cause such destruction in the lungs that it leads to bleeding. Like these people, when they cough, they will actually cough up blood. So that's not a good thing. It's usually spread through droplet transmission. And one of the interesting things about this bacteria also is that it has a really nice capsule around it that protects it from phagocytosis. Walking pneumonia. We talked a little bit about this. Walking pneumonia is caused by Mycoplasma pneumoniae. And does anybody remember what is something that's unique about the genus Mycoplasma? Right, no cell wall. So let's think about that. If a person had walking pneumonia caused by this bacteria, could I treat it with penicillin? No, because the target of penicillin is the cell wall, which this wouldn't have an effect on that at all. Okay. Now, the reason it's called walking pneumonia is because a lot of the initial symptoms are so mild that these people don't really know what they're infected with, and so they kind of literally like they're walking around with this type of pneumonia, not really knowing exactly what they have. Um, there's a cough associated with it, but the cough is very dry and it's very mild, and it's just something that is not very readily recognizable. And then later on in the disease, they get like a fever and malaise. And well, the number one treatment for this is erythromycin. Also, if while any age group can get walking pneumonia, which age group can you guess is more likely to get pneumonia than any other? Well, look at the incidence rate here. Look, those are not really old people right there. That's like children. Children are more likely to get it, right? Because they most likely get it in schools and daycares and things like that. Another type of pneumonia, it's called chlamydial pneumonia. It's fairly rare. The bacteria that causes this is Chlamydophila pneumoniae, usually transmitted through the respiratory route. A lot of the symptoms are very similar to mycoplasma pneumonia, and the treatment is also the same. It's usually treated with erythromycin. Legionnaire's disease. Legionnaire's disease is caused by the bacterium Legionella pneumophila, which is a gram-negative bacterium. And the only way that this is spread is through fine mists of water that carry the bacterium. And this could be fine mists of water sprayed out from air conditioners, spas, humidifiers, or fountains. And it's fairly rare, but occasionally we do hear of outbreaks of Legionnaire's disease here and there. Okay. Just to kind of give you an example of this, I mean, several years ago, there was an outbreak of Legionnaire's disease at Grady Hospital. There was one floor of the hospital where people started getting Legionnaire's disease, and they traced the bacteria to the air conditioning lines. Not to scare you or anything, but there have been cases of people getting Legionnaire's disease just by going to the grocery store. If you go to the grocery store and you go to the place where the lettuce and the broccoli and all those, the produce is at, you might remember that there's that, like, they spray out the mist of water to kind of keep the vegetables nice and crisp and stiff. Well, if those water lines spraying out the bacteria are not clean, it could be infected with Legionella pneumophila, and there have been cases of people that got Legionnaire's disease from places like that. So again, it's primarily transmitted through mists of water. Some of the initial symptoms resemble cold or flu-like symptoms, and then it kind of progresses into mild, fatigue and malaise and things like that, and it just kind of gets worse from there. The number one treatment for this is, you guessed it, erythromycin. Okay. All right. Now, some facts about the bacteria. The disease is considered to be a emerging infectious disease because 50 years ago, this was a disease that was almost unheard of. The very first time that it was recognized was in 1976, where in Philadelphia, there were a lot of people attending a conference at a hotel in Philadelphia called the Legions Conference. It was basically a Legions conference for people that were Legionnaires. It's a type of military group. But anyway, so they were staying at this hospital and doing things there, and all of a sudden people started getting this weird type of pneumonia that, had never been seen before. And when they analyzed the samples from these individuals, they recognized that they were infected with this bacteria. So they named the bacteria after, this, and they, called the disease Legionnaire's disease. And if you kind of look at this graph here, you can see that for the most part, we see higher cases of Legionnaire's disease in the summer, where there's more of a likelihood of people going out and being exposed to fine mists of water at pools and things like that. All right. Okay. So I tell you what we're going to do. Well, we're going to talk about some viral infections of the lower respiratory tract as well. Let me see here. This actually takes a little bit longer to talk about. So I think what we're going to do, rather than get into it and then cut halfway, let's stop here. So we're going to end a little about 10 minutes early. But again, the reason we're ending a little bit earlier is because if I did start on this, there's a lot to explain here. So I don't want to like cut it midway and say, hey, you got to go. So let's stop here and we'll pick up with talking about viral infections of the lower respiratory tract on Wednesday. All right. Does anybody have any questions about anything before we call it? All right. Well, if there aren't any questions, then I will talk to you all on Wednesday, and I'll see you then. All right. Take care, everybody.